My name is student Dr. Nolan Sjo. Today we're going to be taking a look at a case presentation on Sjogren syndrome. Holly is a 23-year-old Caucasian female presenting with low-grade fever and shortness of breath. An information deficit there is we'd like to know how long that fever has been occurring and how long she's been experiencing shortness of breath. She's also reporting a 10 to 12 pound weight loss. We'd like to know over what period of time that was occurring and also whether it was intentional or not. She has occasional pruritus that awakes her at night. Pruritus is an all-over itching feeling. She's also reporting aching muscles and joint pain of small bones in the hands and wrists. Another information deficit there is we'd like to know how long that was occurring for. She's reporting fatigue and generalized weakness. Again, we'd like to know how long that was occurring for. And also occasional dysarthria, which is trouble speaking. Looking at her past medical history, she was seen by a physician 2 years ago for a tonic seizure. The physician discharged her with a diagnosis of idiopathic seizure disorder of unknown etiology. Idiopathic meaning he could not determine the cause. When looking at the physical exam, we noticed that her temperature was 99.2 degrees Fahrenheit, which is febrile or a little high. She had a scaly, slightly erythematous facial rash with malar distribution that appears to spear nasolabial folds. She had focally shoddy lymphadenopathy of the cervical lymph nodes bilaterally. By shoddy lymph nodes, we're meaning that they're small and hard, and usually of no clinical concern. The term shoddy is given by physicians, usually meaning like small buckshot pellets from a shotgun or little bullets in their feel. She had bilateral proximal muscle weakness of the upper and lower limbs, but still had her deep tendon reflexes. Imaging and labs were taken, and a mediastinal mass of 6.4 centimeters in diameter at its largest point was found. It was solid with some heterogeneity, but no evidence of cystic features. She had mild hepatosplenomegaly without focal or mass lesions identified. Hepatosplenomegaly is enlargement of both the liver and spleen. A CBC was taken, or complete blood count, and it was found that there was moderate normocytic normochromic anemia. Normocytic meaning that there were normal-sized red blood cells, but there was a low number of them. Normochromic meaning it's a form of anemia in which the concentration of the hemoglobin in the red blood cells is within a standard range, but again, there was a low number of red blood cells in the blood. She had scattered atypical lymphocytes and mild thrombocytopenia. Based on the symptoms presented, I came up with a differential diagnosis list. Starting from most likely to least likely, I included Sjogren syndrome, systemic lupus erythematosus, or SLE, HIV, drug-induced SLE, and tuberculosis. From that, I think Sjogren syndrome is the most likely, followed by systemic lupus erythematosus. I don't believe it's exactly systemic lupus erythematosus. I think it's a more defined facet with Sjogren syndrome, but they have been shown to occur simultaneously in many cases. I do not believe it's HIV. From all the symptoms that are presenting, I think Sjogren syndrome fits a little bit more. Drug-induced SLE I excluded because of the drugs she was taking. The drugs that cause drug-induced SLE are more for heart arrhythmias and heart problems, and very little of the time is it anticonvulsants. And also, it's over a period of 3 to 6 months, which we believe that she did finish taking these drugs longer than that period. And also tuberculosis, which could explain the mass, does not explain the rest of the syndromes. Some tests and studies we'd like to run on Holly include an HIV immunoassay. By immunoassay, I mean an antibody screening test, screening for the HIV antibodies, which at this point would be being produced in the body. For Holly, this test would be negative. We'd also like to do a PPD test, which is a skin test using type 4 hypersensitivities, looking for tuberculosis. After administration and 24 to 72 hours later, we'd expect to see a reaction. In Holly's case, we would not see a reaction. We'd also like to run an immunoassay for anti-SSA and B antibodies, which in studies have shown high correlation to proving and diagnosing that a patient has Sjogren syndrome. We do want to biopsy that mediastinal mass because any mass we want to check to see if it's cancerous and also see if it's malignant versus benign. After biopsying the mediastinal mass, we believe it's more likely Barrett's esophagus, which is caused by chronic reflux and GERD, which can be associated with Sjogren's syndrome since it's systemic and affects many areas of the body. There would be metastatic changes and hyperplastic changes in the esophagus that could be causing that mass. In this case, that mass was shown to be benign and just more the hyperplastic changes. We'd also like to do ocular tests, including the Schirmer test, in which the eye is numbed with a topical anesthetic, and then a piece of testing paper is placed into the eyelid. And over a period, we wait and see how much tears are collected on the piece of paper. For Holly, we'd expect this to be little to no tears collected, which would be much more indicative of Sjogren's syndrome. We'd also like to do some salivary tests, including a biopsy of the salivary gland to see if there's changes within that salivary gland, which we would expect, and that would show that saliva is not being produced due to her systemic condition. We'd also like to do an unstimulated whole salivary flow collection, in which saliva is collected for 15 minutes and then measured. In this case, we'd expect there to be less than 1.5 milliliters of saliva collected. Sjogren's syndrome is an autoimmune condition. It is characterized by exocrine gland dysfunction and dryness of mucosal surfaces. Just like SLE or systemic lupus erythematosus, the body is fighting itself. The eyes and mouth are usually affected, but it can also be the nose, pharynx, larynx, and vagina. So with those dryness of those mucosal surfaces, you especially see a gritty feeling in the eyes, really dry mouth with trouble eating, which could explain her weight loss. The cause is unknown, but it's likely a combo of genetic, environmental, and hormonal factors. It's also have shown to be a high degree of polyautoimmunity, meaning a lot of other autoimmune conditions can accompany this. Women are affected in a 9-to-1 ratio compared to men, especially Caucasian women, as it's shown to be European originated. There also is a genetic risk factor of HLA class II genes, meaning that your T helper cells are affected, which in turn affects your B cells. There's a wide spectrum of clinical manifestations that are displayed in Sjogren's syndrome, including dry eyes and mouth, fatigue, sleep disturbances, anxiety, joint pain, respiratory systems, GI symptoms, and dry skin. But on the next slide, I'm going to show you which ones are more indicative of this case. So as we can see here in the ones highlighted, we can see the fatigue that she described is definitely attributed to Sjogren's syndrome. With the body fighting itself, there's less energy being used in daily occurrences. We do not see the dry eyes and mouth, but it is possible, especially with that weight loss we see. With a dry mouth, it's going to be extremely painful to eat, and so this could explain her weight loss over a period of time. It is contributed to sleep disturbances, which she's reporting. There is a level of anxiety that comes with Sjogren's syndrome, but because this patient did not display that she had anxiety and described that to us, it is something that could occur later on, and more so actually after she finds out this could be potentially her syndrome. Joint pain, because rheumatoid arthritis is highly correlated with Sjogren's syndrome, it does explain the joint pain she's feeling in her hands and small fingers. The respiratory systems we're seeing of dysarthria and shortness of breath are also explained because this is a systemic disease. It can be affecting her respiratory system as well. We're not seeing GI symptoms, but we could see reflux at night, and with that reflux she could be getting Barrett's esophagus, which there's a hyperplastic change in her esophagus in that mediastinal area because of the chronic reflux. And with that dry skin, that definitely explains that occasional pruritus she's having all over her body. Management of Sjogren's syndrome is not easy because there is no known cure. All we can do, as of now, is just treat the symptoms as they present and try to ease the discomfort that it causes. For the ocular discomfort, we can give eye drops. which we usually give a preservative-free artificial tears to help keep those eyes moist. For oil treatment, we want to give mechanical stimulation to try to produce more saliva. If that's not working, then we can try saliva substitutes and just make sure she's having adequate fluid uptake. She's also going to want to avoid any type of irritant that could inflame her throat or any mucosal surface that's lacking that protection now, such as smoke, coffee, nicotine, or alcohol. Antimalarials have actually been shown in some cases to help reduce the symptoms of Sjogren's syndrome. Corticosteroids can also be given to help with that pruritus and all over itching. And also vitamin D supplementation may be necessary, as it's shown in a lot of people with Sjogren's syndrome that they are vitamin D deficient. For patient education, I want the patient to follow up with me every 6 months so that we can keep this under wraps. I will refer to an ophthalmologist to keep her eye issues under control. Because of that loss of fluid, she's definitely predisposed to getting corneal ulcerations, which could lead to a loss of sight, which she knows that might be a possibility if she's not keeping this under check. As well as dental issues, since she's not producing saliva, she does not have that antimicrobial properties there, and it could lead to dental decay and loss of teeth. There's also been studies that have shown a high correlation with non-Hodgkin lymphoma arising with Sjogren's syndrome. Because of that mucosal dryness, she does have to worry about sexual dysfunction as a young woman. If she does seek that in the future, it may be something she may want to use lube for or seek other options. She does need to worry about the depression and anxiety that may come with this disease because of just how tough it is on the body and how she may feel very much out of place. She will definitely want to keep that under check. The prognosis is not great for Sjogren's syndrome. It definitely has an increased mortality risk by having it. And since there is no cure, that in itself can lead back to my previous point about depression and anxiety. There is good news, though, because there is the Sjogren's Syndrome Foundation, which is huge. It's just a huge community and something she can find comfort in, knowing that others are experiencing the same thing she is. These are the resources I used, and thank you so much for listening to my presentation.